Neurotrauma Centre, but we're also the National Centre for Spinal Injuries for the country. So we're a high volume unit covering all aspects of spine care. So I have no financial disclosures, and I will disclose that there are other VR and AR systems available, but BrainLab and Magic Leap are what we have in our system. And so that's what I have the most experience with, and we'll share some of my knowledge and experience with. So what is it? So AR and VR are rapidly expanding areas of spine surgery. I say a few years ago, you would never really have thought about this. And in all aspects of surgery, really, they're coming on leaps and bounds, but say it's certainly now becoming quite commonly used in spine. So the terms are often used interchangeably when really they shouldn't be. So AR, so augmented reality, is an interactive experience of a real world environment. So basically what we're doing is we're adding digital elements to a live view, where VR is a completely immersive sort of in the digital world. So you're shutting out the physical world completely. So one of the best examples of augmented reality is the likes of like a flight simulator or a car simulator. Whenever you see the pilots learning to fly, they have to spend so many hours in the flight simulator looking at practicing the techniques in their landing. So that's really where the ideal world for us would be going. Other advantages with using it allows us an accurate 3D visualization of anatomy, of implants, of tumors. So there's lots of uses for it. And it's a completely immersive educational tool. I mean, our trainees and fellows love using it. So where it can be used, at the moment it's being used predominantly for training and simulation for all levels, right, from medical student through to senior fellow and consultant. But I say we use it a lot for preoperative planning. So particularly for those complex cases, it's excellent for planning screw and implant positions, for planning tumor resections, for planning near decompressive margins, all of that sort of thing can all be planned preoperatively. Education, both for surgeon, trainee, but also for patients. Patients are becoming more and more involved in their care. And certainly, I don't know if it's been seen across the world, but certainly in the UK and Ireland, there have been a couple of TV series on in the last year or two showing patients different conditions, and they've had the VR goggles on to show them. And one in particular, just after COVID, was showing a patient post-COVID lungs and what had happened, and the patient had been really quite sick, but a real understanding of what had gone on in his body and why his body had failed him, requiring intensive care. And I say they found it really quite an emotional experience. And I say having many of our patients have now seen these kind of programs and are now aware that this technology exists. So it's the sort of thing we need to be aware of. And if you have the ability to demonstrate or educate your patients with that, I think it's certainly a very worthwhile tool. And that leads obviously very nicely on to consent. So consent is a very difficult process. And how do we make sure that patients have fully informed consent? Everybody is different in how they learn and how they understand. So in the days gone by, us just telling a patient what we were going to do, so this is what it is and this is what the risks are. Patients we know don't remember everything that's being said. So then we started off augmenting this with leaflets, then we augmented it with videos, and saying now the next augment is going to be bringing in VR or augmented reality into the consenting process, particularly for those complex cases, so those complex deformity and those terrible complex tumors. But even in the post-operative period, it can be helpful to show. So you can't always use it in the emergency setting, but I say it can be useful in the clinic setting to show patients what actually had gone on in that dislocated neck that you were doing, so they get an understanding of how serious their injuries were. If patients are interested, I say it can be very helpful for developing an understanding and also helping to come to terms with those that have significant weakness and things afterwards. So the question then becomes why. I say some people are very pro-technology, and we certainly in our unit are very pro-technology. Others are much less. And I say at many meetings, whenever I give talks on navigation or robotics, the question is always, but why? I do it very well without. And there is very limited evidence around augmented reality and virtual reality so far. So there are multiple systematic reviews looking at the stuff, but I say most of it is around education and training so far. I say in this one by Uninol, which was published in 2023, showed that VR-assisted training improved accuracy compared to lecture-based. And that makes perfect sense when you think about it, allowing students and trainees the chance to get fully involved, to see the 3D anatomy in full, to play with the 3D anatomy, so to spin that spine around, to walk through the spine, to be able to do that. It obviously is going to give you a much better idea of what you're dealing with and allow you to place more accurate screws. Preoperative planning using VR shows reduced operation time, reduced blood loss, and in particular radiation exposure. Now, that's something I'm very passionate about as a surgeon. The old-fashioned ways of doing navigated screw or percutaneous screws with fluoro shots where we expose both the patient and ourselves to a lot of x-rays. I say that's, for the patient, it's terrible. It's a lot of x-rays and it's a lot of radiation. Even worse for us, I say that patient is getting that as a one-time deal. We're getting that 3, 4, 5 times in the day and several times in the week and several times a month and over the years. It's a huge exposure for us, and say it's something we want to be minimizing. Pedicle screw accuracy seems to be what we have at the moment as one of our baseline measures for how good something is. Now, I think that also needs to change, and that's an entirely different talk that I'll give on another day. But I say the accuracy is proven to be around 96 to 100%, so similar to that of navigation, be that freehand navigation or robotic. Again, Schwab et al. Showed another systematic review looking at potentials, and they felt that AR and VR were promising technologies that would soon become part of the standard of care in spine surgery. So say big names endorsing it. Here looking at disruptive technology in spine surgery and education, virtual and augmented reality. So Europe et al. In Open Neurosurgery in 2021 felt that it was easy to apply and to implement, although they did say that further studies needed to be used both in industry and also multi-institutional. And I say that's where I think we're at the moment. That's the stage we're at of doing industry and academic partnership. And we're certainly with BrainLab. And I say looking at using multi-centered studies now to see where the technology can take us in the future for both education, but also more importantly for clinical practice. Yet another review of the literature showing favorable outcomes, so favorable metrics for, again, target screw accuracy, radiation exposure, and clinical outcomes for patients here. So again, all very positive in the literature towards that. Yet another one showing it's robust and reproducible medium for surgical training. I say training education, also something we're very passionate about in the matter, and certainly I am as well. And it's, again, very, very useful tool to have in our armamentarium for training, I say, and not just in the senior fellows and registrars that are interested in spine, but also for all of our trainees, both in neurosurgery and orthopedics, and right down to the medical students. To say they love it. The medical students love getting the VR headsets out and getting an understanding of the anatomy. It's a great way of teaching anatomy. So I'm going to show you a very simple case. I say, and lots of people will criticize and say you did not need to use any of that technology for doing this case. I say we have all this technology in our hospital, and so we use it, and we use it very frequently because that's how you get good at something. So I'll just demonstrate a very simple case. So this is a 66-year-old who had a fall from standing height. She had no other injuries other than her spinal fracture. And she was Asia E. I say she had past medical history of COPD, hypertension, and depression. She's a smoker, and I say her surgery was just done on Tuesday past there. So a very recent case. It's just an example of her fracture on her preoperative CT. She had an MRI done as well preoperatively, so no significant posterior complex ligamentous injury, but she had no hematoma, but I say felt to be more unstable given that vertical split. And she had significant pain, so we uploaded it onto our BrainLab software. So as you can see, for those with very astute eyes, they marked it wrong here in terms of the T12 and the L1. It's actually an L1 fracture, I say, so everything got moved down one. That was what the computer thought it was right, but I say we moved it all down from there. I say, so nothing is infallible. We placed our screws on the planning, and this is what we're looking at here on our planning software. So I say you plan our screws, so most people will do this so far, and I say it's done very, very commonly. So you can plan your screw length, plan your screw diameter, make sure you put them exactly where you want in terms of your trajectories. I say, and then from then, I say we can check that our screws are where they should be. So as I say, when you scroll through your screw, and on the bottom here, what you're seeing is a trajectory view. So making sure that screw is within the bone the whole way through. I say, so a nice little tool to have, I say, and that's where most people would get to in terms of their preoperative planning. But we took it one step further. So we printed off our report, tells me what screws we were using. So 7x45s up at T12, T11, T12 as it was in the end, I say, and then down to the 6x45s as we got a little bit lower. And our rod length, as you can see, we're going to be around the 120, 125. So just gave us an idea of what implants we were going to be using, particularly in the day and age where implants are individually packed. It's nice to know in advance what you're going to use. Then most people, I say, would stop there and just go off and do the operation. We took it one step further, and I say we got out our fancy headsets here, and this is not my operating room. This is actually just a snapshot of me in Munich in BrainLab's headquarters. So I say not my operating room, but the fancy headset that we put on at that stage. And this is what I see when I upload that plan into my VR system. So I say this is standing outside theatre because the system we have at the moment is not licensed for use intraoperatively. And here you can see it brings me up a 3D model of the spine with my screws in position. I can spin that model around, I can walk around that model, I can walk through the model, so I can stand within the spinal canal and look and make sure there are no actual medial breaches. I can spin it around here and see my trajectories, make sure I'm not breaching laterally. In the case I can see the fracture here in great deal of detail, and I say I can move it around. I say, and this is a view of what I'm seeing, but this is actually being streamed onto a laptop, and I say my BrainLab rep Mark here is taking the video, so I cannot take any blame for the shaky video. But I say this is what we're looking at. I say from the back, I say I can, you're about to see me start to walk through a pedicle, but we'll stop it there. Other techniques that we have available are, say, once you're there, you can use your pointer, and I say this is me then bringing the CT up on top of the screw technology here. So I say I can use pointers so I can get trajectory view. So if I thought, you know what, actually I can get a screw down an extra level, I can see if that's possible by putting the projector onto it. I can bring up aspects of my CT on top of it here separately, so I can check in a bit more detail onto something. I can remove things. This was just a CT upload. It wasn't a CT and an MRI, but if I had both of them overlaying each other, I can remove the bone to look at the spinal cord or individual nerve roots. So very helpful for tumor and resection. I can remove those separately and do that there in sort of live action there. So I say it's a nice little tool to have in terms of planning and to really get to grips with the anatomy. I say not such an issue in this more simple case, but I say for those very complex cases, it's really great to get thinking and to really get your head in the game whenever you're doing complex cases. And I say these are very, very helpful for big complex cases because you can be doing it and planning it for weeks in advance and really just playing with it on a regular basis to really get a full understanding of what you're doing. Then I say what I can also do is I can also go, do you know what, I've also live got my screen of my CT there, and I say I can have an axial and a sagittal of my CT, and I say you can see I've got my 3D model blocking your sagittal view at the moment. Where that yellow cursor is, I can scroll through my CT and you'll see that live moving through my 3D model. I can move and look at both sides, I say, and I can double check a screw placement as we're going from that point of view. So again, all of these things can then be adjusted. So if I said, you know what, I don't like that L3 screw, I'm not happy with it, then I come back out of the system, I adjust my screw and I can go back and look at it again. So basically I'm allowing myself to place almost perfect screws every time, or in those very difficult cases, place the best of the worst screws. So when you look at pedicles that you think, you know what, I can never get a screw down now, but you need to get that screw in there so you can plan your best in technique or your shortest or your longest screws. And it allows me to really sort of push the boundaries a little bit with my screw placements. Then obviously you have to turn, it's all fun playing with it all day, but I say you have to then turn that into reality. So then I hand my plan over to my registrar and my fellow here who are going to do this operation. So this is Rich and Kev seeing their software in the background here. I say this is them doing this as a percutaneous case, which took them about 15-20 minutes to put all the screws in. I say because we had it all planned out. So the screws were all available and ready to go. So this is them doing that. I say, and next you'll see this is our post-operative check x-ray. We didn't bother putting screws into the fracture level. And you can see it looks very similar to what we had pre-operatively planned. So really looking at where the future is. So hybrid navigation, this is Professor Butler and I standing in BrainLab's HQ back in March there when they had just released or were in the process of releasing the technology to be used intraoperatively. We have that technology en route to us as we speak. I say, and we will be doing the first case of this in the Mater Hospital, hopefully in 2 weeks' time. So very excited to be using that. And basically what we'll have there is that view that you were looking at with all my navigation. I will be able to do live navigation with it through my virtual headset. So I will not have to look at the screen there. I can be looking down at my patient and seeing my overlaid CT and MRI scan. My understanding is that we will be the first in the world to use the BrainLab technology intraoperatively unless I'm beaten by somebody between now and the 10th of September. So other uses, I say we are, as I said before, a major trauma centre, and we use this technology as well for doing pelvic fixation to allow more percutaneous pelvic fixes, and even some of our complex foot and ankle and tibial trauma. The guys will preoperatively get a look at the CT in much more detail. I know CTs can be put onto a 2D screen with 3D reconstruction, but it's not the same as being able to actually see it in a full 3D system. Really, the future with VR goggles and AR goggles and headsets is really unlimited. I say you can actually have on your screen in the VR set, you can have anything on there. I say you can have your neurophysiology, your electrophysiology up there. You can have patient notes being pulled into it, so you can have constant update of that. So really, the technology here is endless and really evolving very, very rapidly. So very pleased and I'd like to be part of it as we're developing this and moving forward. And certainly I can only encourage those, if you get the chance to see it or have a look at it or play at it whenever you're at any of these meetings, absolutely go and have a look and have a chat with this. I say I'm not a brain lab rep, but any of the companies that are doing it, I say it's certainly worthwhile because I think this is really where the future is at. And as Stuart Brand said, once new technology rolls over you, if you're not part of that steamroller, you're part of the road. So absolutely be part of that steamroller.